Okay. Hello, everyone. Hi. Welcome back to the UCLA Center for Health Policy Research's 2017 Health Policy Seminar Series. My name is Gwen Driscoll. I am the Director of Communications for the Center. And we've been spending our summer talking about the safety net. Last month it was on public hospital reform. Today we're going to have a fascinating and unfortunately more relevant than ever discussion of what community clinics are doing to reach the uninsured. But first, a note about our next seminar on August 22nd. We will be talking about Parks After Dark, which is a Los Angeles County program that began in 2010 as a prevention strategy of the county's Gang Violence Reduction Initiative. The program was designed for communities with higher rates of violence, economic hardship, and obesity prevalence. The center was the evaluator of this innovative program in which PAD, Parks, stayed open late on Thursday, Friday, and Saturday nights in the summer, offering a variety of safe, free, recreational, and cultural activities for people of all ages. What started out as a program in 3 parks has now been implemented in 21 throughout Los Angeles County. Please join us at this August 22nd seminar to hear lead evaluator Nadare Parat, who is the director of the Center's Health Economics and Evaluation Research Program, talk about how the Parks After Dark program evolved into a key county strategy to promote health, safety, equity, and community well-being. And just a note about this seminar, it will not take place at our usual noon time frame. For a variety of reasons, it's going to take place at 2 p.m. that day, and that day only. So again, that's August 22nd at 2 p.m. Okay, as for today, as always, we will be recording today's seminar. It will be placed on our website at the address you see at the top of this slide. If you are watching online and you would like a copy of today's slides, please email me at second address, gdriscoll@ucla.edu. And please also note that we will have a brief question and answer period at the end of this presentation that I will moderate. Okay. So, federally qualified health centers, commonly referred to as community health centers, sometimes as community clinics, serve as critical safety net providers to those who are uninsured or who may become uninsured. In today's seminar, Center Associate Director Stephen Wallace and graduate student researcher Maria Elena Young will discuss findings from a new study on these centers' efforts to serve the remaining uninsured. And this study is currently available on the center's website on our main page at www.healthpolicy.ucla.edu. So check it out. Specifically, Steve and Maria Elena will discuss strategies undertaken by CHCs in 4 states that reinforce the local safety net through partnerships, improvements to the local health system, and advocacy. This research, unfortunately, has even more relevance today as we witness new efforts to dismantle or, at this point, undermine the ACA and the Medicaid expansion and the implications that could have for the safety net. Our speakers today are experts on health disparities and specifically on the ability of society's most disadvantaged, or lack of ability, to access care. Steve is the center's associate director. He's the chair of the Department of Community Health Sciences and a professor at the UCLA Fielding School of Public Health. He is also a leading national scholar known particularly for his work on immigrants and elder health. Maria Elena is a graduate student researcher here at the center, completing her PhD work on how state policies impact immigrant health. Steve and Maria Elena previously published an October 2016 policy brief on how the ACA led to community health clinics serving millions more people than they did before the law's passage. Today's publication is a complement to that earlier one in that it describes what CHCs are doing to deal with what may only be increased demand. So please welcome Dr. Stephen Wallace and Maria Elena Young.
Thank you, Gwen. So Maria Elena and I are going to do a tag team. I'm going to start, provide a little context. She's going to give you the guts of the policy brief, and then I'll wrap up with some conclusions and recommendations. So, want to acknowledge the other contributors to this project. This has been a 2-year-long plus research project. Other researchers include Nettie Pratt and Michael Rodriguez, as well as Ame Bonilla. And of course, none of this would have been possible without our funder, the Commonwealth Fund, which is a private foundation in New York that does a lot of work on community health centers. We also want to thank all of the respondents, quite a few community health center directors and other staff at community health centers around the country gave us their time in both telephone and in-person interviews. And given all the work that they're doing, this was precious time that they provided to us. Okay, so for today's presentation, I'm going to briefly describe the role of community health centers in the current safety net. Then Maria Elena will talk to you about the partnership strategies that we identified in 4 different states across different community health centers, the strategies and factors that led to the success of those initiatives, and then some recommendations and conclusions. So let's start with where the safety net is today. So this project started out soon after the Affordable Care Act passed, which had a large expansion of Medicaid and a number of provisions that were expected to help community health centers. On the other hand, the expansion of Medicaid also led a lot of people to worry that maybe community health centers would actually lose patients as the newly insured would go elsewhere. This entire project assumed that the ACA was here to stay, and as of last Friday, there was a slide that said, insert current context here. So we know that the latest attempts to repeal the ACA have failed, but there continue to be attempts to undermine Medicaid, perhaps change it into a block grant. There are administrative attempts to reduce funding to support Medicaid expansion and ACA expansion, which benefit the community health centers in a number of ways. And there may be additional attempts to eliminate it altogether. So given, well, the project started assuming the ACA was ongoing, whether it continues or not, this study is still relevant. So we first started by looking at the role of community health centers in the safety net in the context of the ACA, and published this policy brief that Gwen mentioned, which we found that the community health centers were not losing patients and that they were continuing to expand and play a vital role in the safety net for both insured and uninsured patients. We found that community health centers were expanding broadly and serving more insured patients. So the design of this was to take 2 states, large states where Medicaid was expanded, so that was California and New York, and then 2 states where Medicaid was not expanded, so Texas was a logical one. And we're also very interested in immigrants and the policy context for immigrants. And so we picked Georgia, in part because it has a very active political discussion around immigrants and the role of government. So what we found in the first part of our study was that in expansion states, as you would expect, there was a rapid growth in the number of people seen in both the insured and uninsured. What was interesting here was that the number of insured patients grew faster than the decline in the number of uninsured. So basically, community health centers were both continuing to serve as safety net providers for the remaining uninsured and bringing in more of the remaining uninsured as a proportion, even as many of their uninsured patients became insured patients. And this trend has continued. 2016 data aren't available yet, but through 2015, the same trend was occurring, which was a slow decline in the uninsured patients in community health centers and a much faster increase in the insured patients. What we found surprising, however, was that even in non-expansion states, the numbers of insured patients increased. So this was not due to Affordable Care Act policies, because they're generally targeted to people at higher incomes than use community health centers. So what we found is that a lot of people who had previously been Medicaid eligible but not signed up were being reached by the enrollment and outreach people who the community health centers had newly in their staffs, and the awareness overall was increasing. So you see in both Texas and Georgia, the number of insured patients increased, not as much as New York or California, but increased nonetheless, while the number of uninsured patients was relatively stable. What was important in these areas was that overall community health centers continue to serve high numbers of uninsured, even though their financial and staffing resources continued to be limited, especially in the non-expansion states, because they were not getting large numbers of new Medicaid, small numbers but not large numbers of new Medicaid patients. In addition, there was an increased competition for staffing as private health insurers were trying to scoop up clinical staff. There was limited administrative capacity as these clinics grew in size in terms of the numbers of patients and the complexity in terms of the grants they were applying for, with pretty much the same levels of administrative staffing, and high levels of both financial and political uncertainty, especially in states that had not expanded. In interviewing some of the directors around the impact of the ACA, one of the ones in California said, well, I think there was a tremendous amount of publicity and buzz around the rollout of the ACA, and that was true both in expansion and non-expansion states. And the whole concept of healthcare as a right and not a privilege. And you're hearing more and more discussion about this now with the proposed repeal of the Affordable Care Act, that there's a broader sense that everybody should have access to healthcare. So a combination of the information out there and the fact that there was a huge expansion allowed us, this California Community Health Center, to see a lot more of the uninsured and the undocumented who are seeking services. So this reflects the fact that the remaining uninsured continue to be reliant particularly on community health centers. So the strategies that they undertook to deal with changes in the ACA and their environment included things like increasing organizational capacity, becoming even more important to the local safety net, and increasing their integration to broader systems. And so as we were watching community health centers at the local level adapting and changing, we realized that they were in dynamic interaction with the environment around them. And that led to this policy brief where we went and looked at some of the more external strategies that they pursued. And Elena will tell you what we found.
Right, thank you, Steve. So as Steve just mentioned, as we were conducting interviews with the community health centers across these 4 states, we were hearing over and over again different examples of where they were working with partners across different sectors to not only bolster their own organizational capacity, but through partnerships, were actually contributing to strengthening the local safety net that they were working in, and also to help integrate their own health services into the broader healthcare system that they worked in. So for the second phase of the REACH study, we really wanted to understand those strategies better. So, let's see here if I can change, oh, I can, there we go. Really the objective of the second phase of the REACH study was to focus in on the types of partnerships and strategies that community health centers were engaging in, and kind of understanding what partnerships made those strategies possible. So first, we really wanted to focus on a specific type of strategy. We wanted to look at examples where community health centers were working beyond their own organizations and connecting with other organizations, both in the community health center sector and other aspects of the health and non-health sectors, to have a larger impact on the safety net. We also really wanted to focus at different levels, both kind of geographically and within health policy. Our conversations we were having with community health centers made it clear that they were working with a wide range of partners, and some of them were very local, but also some of these were taking place at the state level. And then finally, we really wanted to understand who these partners were, kind of what were the partnerships that they were able to develop, what were the factors that allowed them to develop these sorts of partnerships so they could engage in strategies like this. So a lot of research on community health centers really looks organizationally at FQHCs themselves. So the goal of this study essentially was to step outside the clinic door and, as Steve said, really think about the external strategies community health centers were engaged in, and sort of think about, in the post-ACA environment, how community health centers were engaging in the broader health systems in which they operate. So it's a unique study in sort of thinking more broadly about community health centers as part of those overall health systems. So to understand these partnerships and strategies, we took a case study approach, and we selected a purposive sample of 4 cases in each of the 4 states, so 1 each in the 2 expansion states, California and New York, and 1 each in the non-expansion states of Georgia and Texas. And we selected cases based on sort of both this idea that there's strategies and partnerships unfolding at different levels of the safety net and sort of different aspects of health policy, and also recognizing that these strategies and partnerships are unfolding at different geographical scales, so very locally all the way up to the state level. And our analysis included the initial first 30 interviews that we conducted with community health centers in the 4 states. And then we conducted an additional round of interviews with community health centers stakeholders. So this included, depending on the case, health departments, hospitals, community health center and primary care associations, and other sort of advocacy groups and funders. And all of these interviews took place between 2015 and 2016. So to present the results of our study to you, I'm going to describe very briefly each of the 4 strategies and give you a little bit of background on like the motivation behind each and what were the key elements of the partnership. And then I'm going to discuss themes that cut across all 4. And really the goal of highlighting these 4 strategies, both here and in our brief, is not to suggest that any single strategy is the best practice that all CHCs should adopt nationally. Rather, it's really to highlight examples of where CHCs have effectively adapted to the context in which they're working to be able to develop partnerships that are having a broader impact on the safety net. So the discussion of the themes after this initial part of the presentation will really kind of get into what are the conditions that make these types of partnerships and strategies possible. All right, so the first case that we looked at was an example of a collaboration of community health centers in Houston, Texas. And they were, at the time of the interviews, working together to jointly provide clinical services and also engage in administrative planning. And so this partnership was made up of entirely of CHCs that were each very mid-size in terms of kind of the number of patients that they were serving. So it meant they had somewhat limited capacity, and they were also seeking ways of kind of improving their organizational efficiency. It also turned out that these 4 health centers were serving neighboring communities in Houston, and the CEOs had very similar values and philosophies about community health center work. So one of the directors from one of the health centers really, I think summed it up very nicely for us and said, we started getting together and saying, we can make a bigger impact collectively. And so essentially by working together, the 4 community health centers were actually able to create something of an integrated health system in an entire corridor of the city of Houston. So their partnership entailed initially really just developing partnerships. The CEO leadership got together and began initial conversations. Those planning conversations were increasingly including other staff, such as the medical directors. And they started with basic sharing of organizational knowledge. So sharing grant proposals that had been successful, sharing each other's internal policies and procedures. And in part, this helped to align all 4 of their practices as organizations, but it was also an opportunity to help one another out and make sure that they weren't reinventing the wheel. And sort of after testing this initial phase of partnership, they were able to apply for funds to engage in offering joint clinical services. And so they obtained a grant to be able to offer pharmacy services and also a grant to be able to offer psychiatry. And one community health center was the fiscal agent, one was the contracted provider, and each of the 4 continued to be the primary care medical homes for their respective patients. And then finally, they received a planning grant from a local foundation that allowed them to hire a law firm that was walking them through the planning process of sort of understanding the legal aspects of sharing services. So sort of understanding issues around patient privacy, but also how they could potentially set up an administrative services organization. So the second case that we looked at was an example of a community health center partnering with a local hospital. And this was a partnership that was helping to facilitate specialty care referrals for the patients at the community health center. So throughout the interviews across the country, as we were doing these interviews, issues around being able to refer patients to specialty care was a major challenge for community health centers. And not only did community health centers struggle to find specialty care providers, but once they had those providers, it was very difficult for there to be care coordination for patients who were seeking care outside of the clinic. So the community health center in Atlanta that we spoke with, they served a very high-risk population that had a lot of needs for specialty care. And it turned out that the local nonprofit hospital was also serving that same population, as they were accessing very high rates of emergency care. So the two organizations felt that they could work together, they could reduce emergency room visits, but also improve care coordination for the patients at the community health center. And so similar to what we observed in Houston, their partnership really, again, began with initial conversations, a process of relationship building. The CEO from the hospital reached out to the leadership of the community health center, and they began conversations about how they could work better with one another. And both organizations were able to sort of test out their working relationship through a small grant-funded project. That sort of helped improve and further their relationship, so that the hospital gave the community health center providers admitting privileges at the hospital so that the providers could sort of follow up and see what was going on with their patients who were seeking care there. And then finally, the community health center decided to adopt the same electronic medical records as the hospital. So at the time of our interview, the two organizations had shared medical records. So a provider at the community health center could make a direct referral for specialty care to the hospital. And at the hospital, if a patient was seen there for specialty care or in the emergency room, a referral back for follow-up could be made directly to the primary care provider. The third case that we looked at was an example of a county-level coverage program to provide access to care for the remaining uninsured. And so this partnership was here in LA County. It's called My Health LA, was actually a partnership of the county that provided the funding for the program, providing funds for primary care, the Department of Health Services, which was administering the program, and the community health centers who were contracted to be the primary medical homes for enrollees. And this partnership really emerged because of an existing relationship between community health centers and the county. There had been two previous iterations of a program where the county engaged in a public-private partnership, contracting with community health centers to be able to provide direct services. And this really laid the groundwork for a program like this to be developed. And when this particular iteration, My Health LA, was developed, there was really two phases. There was the planning and then the implementation. And what we heard from both the clinic and the stakeholders was how important it was to have the community health centers in on the planning phase. So one of the respondents said, you cannot start this planning process and not have the people providing the services around the table. They are serving the remaining uninsured, so they need to be in the planning process. And when the program was actually implemented, what we see is that community health centers are the primary medical home, and people who in LA County who are low income and unable to obtain insurance through Medicaid or some other source are able to get no-cost primary care at these community health centers located in their communities. And the fourth and final example of a partnership and strategy was efforts going on in New York State among community health centers to work together to engage in policy advocacy. So at the time of the interviews, community health centers in New York State, like in many states around the country, were not only worried about policy issues related to the Affordable Care Act, they were dealing with other very specific issues in their state and locally. So for example, there was concern about the level of funding for the state's uncompensated care pool. There was a lot of discussions around access to care for the undocumented and trying to expand opportunities to cover individuals who were left out of the Affordable Care Act. And so what we saw was that community health centers really saw advocacy as an important way to establish long-term relationships that would help them kind of depending on changing political issues, but also it would give them a voice in very directly pushing for specific policies that could benefit their patients and also their organizations. So these partnerships actually really unfolded at multiple levels and with kind of multiple different players. First, we saw that community health centers fostered relationships with their local, state, and federal policymakers. And this was really critical to have allies at all levels of health policy. Community health centers were also working with one another through local and state level primary care associations. And so having kind of a collective voice created an infrastructure for their policy efforts. So for example, the State Primary Care Association is is the case in many states, would host an annual policy advocacy day in the Capitol, and everyone would go to Albany and speak with policymakers about a specific bill that was relevant to their health centers. And then finally, we also found that community health centers were really working with organizations and individuals outside of the health sector to push for policies that were good for their patients, really sort of addressing the broader social determinants of health. So we found that community health centers were working with immigrant rights groups. They were working on issues around transportation. They were working on issues around fair housing. I think an example that really stood out for me was that one of the community health centers found that the local police department was racially profiling patients as they were driving to the clinic. And so the community health center leadership actually worked with the local police department and instituted a cultural sensitivity training to help ensure that patients felt safe accessing services near the community health center. So you can see from these 4 strategies, we've got different examples of kind of a wide range of types of partnerships, types of strategies that community health centers are engaging in. And they're taking place, very locally, literally with a sister health center, and more at the state and even federal level when it comes to things like advocacy. So despite being quite different, we really did observe some very key, critical, common factors across the 4 strategies. And what we found was that sort of certain conditions needed to be in place for community health centers to effectively develop partnerships and engage in strategies that allowed them to have a bigger impact on the safety net. So I'm going to discuss those right now. So first, we heard time and time again from community health centers that it was critical that their partners share a similar mission as them. And I think this sometimes maybe comes off as kind of obvious or maybe even a little cheesy, but it really did come up quite a bit. And I think what was key in this quote here from this director of the Community Health Center in Houston speaks to the importance of having aligned mission and vision. It really helped build the sense of trust and shared priorities. And what we observed was that partners that had a shared mission were able to kind of build for the long term. And having a shared mission and aligned values was really what made a difference between partnerships that were going to be long term and partnerships of convenience, maybe just for like one-time efforts. The second factor that we observed that was really critical to support partnerships and their efforts was community health centers being aware of and be able to respond to the broader political environment. And in many cases, was really kind of being able to understand what was unfolding quickly and what opportunities existed. So community health center leadership dedicated significant amount of time and resources to just sort of staying up to date, maintaining relationships with policymakers and others related to their work. And this allowed them to be responsive to what was unfolding in their political environment. So for example, in New York State, we really observed that policy advocacy was quite agile, kind of shifting depending on changes. And I can only imagine what was happening in the last several weeks in all of these community health centers as the policy environment changed so quickly. But what was really critical was understanding the potential limitations of what was possible given the kind of broader political and financial and funding environment that they were working in. So this quote, second quote here from Los Angeles, I think really speaks to the importance of having partners where there was political will and also political will to invest in the safety net. And the extent to which partnerships with CHCs and their collaborators were attuned to and kind of realistic about what was possible was kind of very important to make sure that they could establish strategies that were going to be successful. And then the next factor that was really critical was just the opportunity to start small. As we see with a couple of the examples here is the partnerships had the opportunity to sort of test out, do we have shared missions? Like, what is possible given the current environment through smaller projects funded often by foundations. It gave them a chance to sort of test out what their relationship looked like. And this really was critical to laying the groundwork for being able to secure larger funding for more impactful projects. In addition, we heard from community health centers that partnerships take time. And so even small grants that gave community health centers a little bit of additional flexibility in their staff resources were critical to being able to put in the time, literally to be able to be at the table physically for a lot of these efforts. And then finally, one of the additional factors that we observed is that partnerships were successful when potential partners understood the benefit and the value of partnering with community health centers. So for example, we see in a couple of the cases that we looked at here, community health centers were approached by their partners. So the hospital CEO reached out to community health center and said, hey, we can reduce emergency visits if we work with you. The county already knew that community health centers could be contracted to provide services. So there's examples of where potential partners already understood the benefit of working with community health centers, and the work wasn't necessarily on the community health center to initiate partnerships. Other people in the health sector and beyond were able to sort of reach out and recognize the importance of working with community health centers. But I think something that is critical to understand with this point is that community health centers spent a significant amount of their resources, especially at the leadership level, educating others in the health system about the role of community health centers. So while there were partners that sort of understood the benefits of working with community health centers, a lot of that was sort of the payback that came from putting in the time to make a case for why community health centers are important to the health system. And so this quote here from Community Health Center really speaks about that. They were successful really at kind of sending a message of how important community health centers were, but a lot of that work actually fell on community health centers. And again, working with very limited staff capacity and funding. So I'm going to now turn it back to Steve, who'll sort of talk about how these findings translate into some concrete policy recommendations that policymakers and funders can pursue to create these sort of conditions where community health centers can be connecting with potential partners and engaging in strategies that help them contribute to a stronger safety net. I'll put this forward.
Okay, so policy recommendations are going to be important. Sorry, I'm finding my place here. There we go. Whether or not anything dramatic happens to the healthcare system. So under the ACA, we saw a large growth in the size and activity of community health centers. These types of partnerships can help make them more effective and more efficient, provide better services, should that continue. Or in the doomsday scenario, when Medicaid gets block granted and there's no more ACA money for outreach and enrollment and other types of services, these types of partnerships will be particularly important in trying to stabilize some of the resources that community health centers need to serve the patients that they have. So on the first point, community health centers should include partnerships in their strategic plans. So a lot of what we saw in terms of the partnerships tended to occur in response to circumstances that were evolving. But if they were proactive in seeking out those partnerships rather than reactive or situational, they'd be able to develop much better and longer term partnerships as part of their relationships. So they can seek partners with neighboring community health centers. In some cases, as was indicated by the earlier quote, the other health centers may not share the same mission, but they can seek out like-minded health centers and develop partnerships, other medical providers, community organizations, and another project we have, we're trying to help connect community health centers with community level services. And the two don't really know each other very well. So simply reaching out and trying to get to know who else is in your community that you can partner with, which provides added strength to both sets of partners. And other organizations, all of which have common missions, complementary strengths, and doing that proactively will help develop stronger partnerships. Foundations have a role to play. I was recently in the Bay Area, and foundations last week, local foundations were wringing their hands looking at the national healthcare system and saying, what can we as a small little community foundation do in the face of all of this turmoil at the national level? And one answer is they can provide pilot funding and support to local community health centers that help them develop the partnerships that serve the organizational needs and missions. So as the case in Houston, it was a local foundation that provided a little bit of pilot money to hire one person that was shared among the clinics, and then provided another little pilot grant to hire a lawyer to help them look at joint operating agreements, and another little pilot grant to help them look into some shared administrative support. So none of those required multi-million-dollar, multi-year national grants. They were small grants from local foundations that help support the local safety net. So foundations think more strategically about how they can reach out to community health centers and offer operating support and other types of targeted grants to build those relationships that ends up having a long-term effect in supporting the safety net. And then increasing awareness and highlighting the value of community health centers. Incentivizing groups other than community health centers in state and local health systems to develop those relationships will feed back and be a win-win in both supporting the local health systems as well as the community health centers by showing the values of community health centers. I was at a community health center convention a couple years ago in Inland Empire, and the community health centers were wringing their hands because the local public hospital really didn't have much interaction with the community health centers. And they felt that if the local hospital would work more closely with them, they could actually help save money by keeping people out of the hospitals. But the lack of relationships, the lack of awareness between the two systems created barriers that increasing cross-system awareness could help with. And finally, providing funding for staff dedicated to community partnerships and advocacy would help community health centers to be more adaptable to local strategies. The community health centers that were involved in advocacy and partnerships pretty much robbed Peter to pay Paul. They were taking little bits of funding and support here, a couple hours from this person, a couple hours from that person. And until you get into some of the really large health systems that can support full-time advocates or government relations officers, you end up having a very fragmented system. So if there was a way to provide funding for dedicated staff, that would allow community health systems to spend more time both in partnership and in responding to the outside environment. So this is the policy brief that we have just disseminated. Partnership strategies for community health centers. And I think what's important to keep in mind is community health centers for years have been a bipartisan service that have been provided in the United States. The community health center grants increased under both Democratic and Republican administrations, and actually even in the most recent repeal bills there was additional money for some community health center activities. So whether times turn out to be good or times turn out to be bad, community health centers need to be ready to continue to serve as a safety net provider and to build the relationships that have been shown through a whole number of evidence-based programs to result in better coordination of care and better services. The difference between what we've seen on the ground and what happens in the SPARC model and the National Association of State Health Officers models is those are mostly planning models that get groups together to talk about planning and then hope that something happens organically. What we've seen across these 4 different states is more than just planning, but action that's helping to build relationships and increase the services available, increase care coordination, and provide increased services to persons in the safety net. And that with ongoing awareness and increasing visibility of these partnerships and improving the alignment of resources and incentives, we feel that community health centers can both continue to serve as key parts of the safety net for the remaining uninsured and even thrive in the uncertain environment in the future. So thank you. We have time for questions.
Okay, Maria, you want to join him? Okay, so the way we do this is we take one question from online and one question from the room and so on and so forth. But I see someone raising their hand immediately in the room, so let's get going.
Were you able to ascertain whether My Health LA had an impact on the percentage of uninsured seen by the CHCs, FQHCs, particularly among the 2 expansion states?
Well, My Health LA is not actually insurance, so they still show up in the data as uninsured.
Right, that's why I'm asking.
But so are you asking, did they have better access as a result?
No.
Okay.
The percentage of the total uninsured seen by the CHCs
Did My Health LA, the partnership that created My Health LA, draw a larger percentage of uninsured or retain a larger percentage? What we saw in studies of Central California is with the advent of expansion ACA is the percentage of uninsured seen by the QHCs dropped. In some of the communities to as low as 3% of their total population served. Because there were so few Medicaid providers, patients stayed with the FQHCs after they got insurance. But with My Health LA, which is seen as a partnership to provide coverage, not insurance, coverage, to uninsured individuals who remain uninsured, as you said, did that draw more uninsured people to the FQHCs as a learning experience for other communities who may be looking at it?
We didn't. This project didn't look at any CHC level data, so I don't think we can answer that in sort of in a empirical sense. I'm just trying to think if anecdotally.
My Health LA is a program for people who cannot be insured on the right. That's why it's
Right.
But the question is, was there potentially a larger kind of uninsured population at each clinic that was actually receiving My Health LA? And I don't think I've had any indication of that.
Yeah, so the total numbers of uninsured went down, but less than the number of insured went up. And in most clinics, they reported that the majority of their newly insured patients were previously uninsured, but then they were drawing more new uninsured patients in as well. And I think what can't be underestimated is the impact of the outreach and enrollment activities that the clinics did.
Yeah.
And that was true even in Texas and Georgia, because they got outreach and enrollment money as well, even though they weren't expansion states. And that's why you saw the bump up in insured patients. It wasn't because there was any expansion, it was because people who were previously eligible but not enrolled were starting to enroll.
Yeah.
And that's actually one of the areas where the administration currently is, my understanding, is starting to cut back in funding, because there was some discretion as to how much money you put into outreach and enrollment. And so those numbers may be going down. If those numbers go down, it's not repealing the ACA, but that's one of the sort of death by 1,000 cuts, and that'll definitely impact the community health centers as well.
Okay, we don't have any online questions, so I'll take another one from the room.
Thanks so much for your presentation. I'm Nina Sponsik, actually gave me ideas on what National Quality Forum is thinking in terms of quality measures that get at this structure of equity. And so, and partnerships is one of the domains. And how can you tell if a community health center or an organization, a provider organization, truly engages in a partnership? And so I think what you've done is provide some possibilities for these indicators. The partnerships, though, take a long time, and I'm just curious, for the 4 case studies, could you talk a little bit more about how long the community health centers have been in the community?
In the community or in the partnerships?
In the community.
That really varied. I mean, I think, for example, in Houston, for example, the community health centers were all relatively new. There was not the same sort of long-standing history of FQHCs as you might see like in Los Angeles County. And so some of them, I mean, I don't remember, you visited one of the ones in,
They
two
were
of them in
10
Houston.
to 15 years old.
Yeah, so quite recent, whereas in, you know, in Los Angeles, for example, you've got community health centers that were kind of at the forefront of FQHCs and have been here for, you know, generations, and they talk about, you know, providers serving the grandchildren of, you know, their original patients. And so I think there was kind of different levels of embeddedness in the communities, but a lot of that actually really, I think, had more to do with their mission than the length of time they'd been in any one community. So, for example, the health center in Atlanta, I don't recall how long it had been around, but it was it had, I think it was serving, even after the ACA, about 80% of their patients were still uninsured, and just really had a long-standing commitment to serving a very vulnerable population, and so sort of trusted and respected in the community because of that. And so it was really kind of more driven by their mission and who the focus and target population was than kind of the duration of their presence in the community. I'm not sure if that kind of gets at what you're interested in.
And the partnerships all did start small, and that was one of sort of the findings. And that's sort of classic relationship building, is you start with something that's sort of low stakes and develop trust. And what was striking was, even though these were some of these large organizations, like the large public hospital, county hospital, in one of the nonprofits in one of the states, it was the CEO that reached out to the clinic, right? So you had to have a level of interpersonal interaction, and really that face-to-face interaction as well, that develops the trust. And you start small with like a referral system, and then you grow larger to where, you know, you actually have electronic medical systems where each can access the others, which is a high level of trust. And there's all sorts of legal stuff they have to go through as well. And the same in Houston. You know, they started with a small little joint project, and that worked, and they did some more, and they found that in situations where one clinic had taken advantage of another, it didn't, right? So it built that trust over time to the point where they were exploring, although we're now pulling back from even the idea of like merging the three into like one large system. They decided, no, that wasn't it, but some sort of joint operating agreement might work out.
Yeah, and even, I think even in Houston, it was an effort that was only a few years old. So, you know, even kind of, again, several years can be a lifetime in terms of, you know, issues around funding and policy, but quite a bit can be done just having the space and the kind of extra funding and flexibility to move those partnerships forward.
Can you talk a little bit more about the size of the organizations, particularly in Houston? These were little ones, lots of sites, or single organizations, and whether there was any indication provided by them on the actual impact that it had on their patient size or operations or financing.
That's a great question. So I don't remember, actually I think it's in the brief, the number of patients. So
It's about 10 to 15,000 each.
Jointly they were serving more than 35,000. So across four, it's still only, you know, kind of less than 40,000 patients. And so, sorry, Nadi, can you clarify what kind beyond that?
If they're really large organizations and they're serving, they have multiple sites, they are a big player, and you pull them together, you have very large you know, power in their size as well as what they're doing, as opposed to little organizations that come together because that gives them a little bit more to operate. And whether you have any idea of the impact it might have had on them.
Yeah. Do you want to talk a little bit? So I mean, I think the first thing is that in part the motivation behind partnering this way was in part due to their size. And I think all four of them had participated in a larger collaborative effort that had happened several years previously, where some foundations had funded sort of like all the community health centers in the region to come together, and there, you know, that was not as successful. And so I think all of them had sort of learned, let's partner kind of with similar size, similar philosophy organizations. So I think being around the kind of size where they needed to band together to be able to share certain administrative functions did have an impact. They were not at the stage where they were necessarily keeping track of that data, and I think kind of data on these issues was kind of across all of the strategies, sort of how to capture sort of the success of the partnership was certainly a limitation. But it was clearly kind of providing them with opportunity to offer services that they hadn't previously been able to offer. So something like pharmacy and psychiatry, which are quite difficult to fund, that was an immediate sort of visible benefit. But I think kind of longer term, it was going to provide them with some stability that they foresaw being a concern. And maybe you want to talk a little bit about there was a lot of mergers going on in the region. Different smaller clinics were being bought up.
Yeah, so Houston was undergoing a lot of change in its safety net system, and there were some clinics that were basically going bankrupt, and some of the other clinics were buying their space. So space was a big issue. But I think the other thing that was important about this is they were starting to do both shared providers and developing the trust where if I refer you my psychiatry patient, they'll come back to me for
Yes.
primary care, right? So that, okay, I know I can trust you because you're not going to steal my patients.
Yeah, I think that's key.
And then they were also exploring avenues for some administrative synergies where they were, like each clinic was contracting out for payroll. And they thought, well, we can't afford to do payroll by ourselves, but if there's 4 of us doing payroll, we can actually bring it in-house, have more flexibility and more control over it.
Yeah.
So there's some things like that. But that trust, as with any relationship, right? You have to trust the person or the organization that you're in a relationship with. So the trust building activities on the small scale where if it didn't work out, it wasn't going to be a huge disruption to the organization was really critical in that.
Yeah.
But you're right, they were small. They were generally small organizations that couldn't do these things by themselves. And so that was a big incentive.
It would be very different if they were large. I think it would look very different.
What was the locus of the leadership that drove the engagement and partnerships from the community health center side? Was the executive or administrator or medical staff?
It was across. You're asking about all 4 cases. Much of this was driven by the clinic leadership. So, certainly in New York in policy advocacy, it was the CEO who was generally the face of these efforts, and really, putting in the extra time to be at events and to meet with policymakers, to be at the table for different meetings. Similarly, the case in Houston, this was really started by interpersonal relationships between the CEOs from the 4 clinics. Similarly, in Atlanta, it was really the high-level CEOs at the hospital and the CHC that initiated conversations. So a lot of this, and I think that's where the recommendation for being able to have some flexibility to bring in staff to focus on these issues, it kind of can help kind of delegate a little bit the burden that was on really the leadership to sort of push forward and sort of motivate these efforts.
And actually, in our last policy brief, we also talked about just overall administrative support. So a lot of the CEOs were writing grants, right? So for the expansion grants, I went and did a face-to-face interview with one of the CEOs in Atlanta, and the day before he had sent off, the latest grant that he had been working on personally. So that's, maybe not the most effective use of CEO time as well. But they didn't have the staffing.
But it also explains why
You got some of this buy-in towards overcoming some of these administrative barriers, more collaboration to break through, cooperatives that brought about efficiencies or lower costs or so on, because only the CEO could make that happen within their infrastructure.
Yeah.
great study.
Although, as we've seen in other work, the CMOs can be a facilitator or a barrier to that also. So it's the leadership sets the tone, but it takes sort of the whole top administrative staff to be on board.
Mm-hmm.
And maybe that's an advantage of some of the smaller clinics as well, as there was
Certainly.
the hierarchy was flatter, and so when people were on board, the whole organization moved.
Yeah.
So for the FQHCs, the major revenues are from 2 sources. One from HRSA, the other from insured patients.
Mm-hmm.
So it sounds like in the last few years they have the same level of funding from HRSA and increased funding from insured patients. So
what's what's your sense of the use of the extra revenues? Like, is it for expansion or is it for do something they cannot do before? Sorry.
Can you repeat the question just in case?
Yeah, so the question just was sort of about how community health centers relies essentially on HRSA funding for FQHC funding, just sort of to be able to provide services to those who aren't insured, and also from Medicaid revenue or other potential insurance, but really those primarily Medicaid. Even very few of the clinics that we talked to were getting patients that were insured through the health exchanges. It was really 95% were Medicaid. And so the question is, the additional revenues that came in from newly insured patients, how was that being used? And I think, well, in part, we see that there was an increase also in uninsured patients that were being served. So overall, the numbers did go up. So a lot of it was still being used to be able to continue to serve patients who didn't have insurance. And I know that they also, a lot of the clinics we talked to spoke about receiving ACA funding for capital projects and also for navigator funding. So that was really actually, I think, the bigger boost that allowed them to have navigators, have them enrollment staff, to sort of like build out their community presence and actually be able to bring in more patients. But I don't know.
So there were a couple things. One is a lot of the newly insured had high levels of unmet need. Mm-hmm. So they would say that, well, we have these newly insured patients and we don't have enough exam rooms because they used to come in once a year, but they've got diabetes and hypertension and hearing problems and something else. So instead of coming in once a year, they're now coming in every month because we've just got these issues we've got to work with. So the actual demand increased even more than the funding that the patients brought with them. And then they were adding lots of services. A lot of them were adding pharmacy. A lot of them were adding behavioral health services. Mm-hmm. A lot of them were adding other types of care. And they were all scrambling just to keep staffed. So nobody talked about trying to figure out what to do with this new revenue. They were right. So the problem was we got this expansion grant. We opened a new satellite site, and now we have to staff it. And where are we going to find the funds to staff it? And we increased Saturday hours, but we only have 10 patients coming in on a Saturday, so we can't afford to keep those Saturday hours, even if over time it might, generate more visits and so forth. So they were all busy spending all the money. They were also, my guess, we have some of their UDS data, the individual level confidential data. My guess is some of them also increased salaries because they were now competing against Kaiser in the Central Valley was giving new primary care physicians a $100,000 signing bonus. So they needed, with the new people mostly exchange covered, they needed more direct care practitioners, and so they were hiring them from anywhere they could get them. And a number of community health centers lost a lot of clinical staff, both physicians and nurses and physicians' assistants and nurse practitioners. And so, they were scrambling to use, I think, some of their extra resources to try to stabilize their staff as well.
Okay, we have time for one more. And before I give it to you, Nadi, is anyone in the room who has not asked a question yet want to ask one? Okay.
I was just going to comment, actually. Yeah. So, I mean, the community health centers actually do get other, they have other income. HRSA not only provides the 330 grant, which is designed to cover their basic services, but they also do a lot of development work and encourage the community health centers to sort of innovate and go into new directions, such as establishing a patient-centered medical home or workforce or lots of different approaches. They also do community fundraising. So there are different sources of income that are coming in. But the reality is the organizations are typically very under-resourced despite all of the money that comes in. So even if they get Medicaid funding is not on par necessarily, even though they get the PPS rate. But still, there's a lot of demand, as Steve mentioned, a lot of resource requirements. What's really interesting is that when you look at these community health centers, a lot of them are also doing a lot of innovative work. They also do a lot of additional services that you don't see elsewhere. The patient navigation, the sort of care coordinator, health education, they're really at the forefront of a lot of these activities. So you visit some of these organizations and you realize they actually provide really great care in a great setting. And that's why supporting them is so important.
You know, I don't remember if it was Texas or Georgia, but one of the clinics was adding a dental clinic. And dental is not covered by Medi-Cal in that state. But they saw that as the greatest need, unmet need of their patients, and so they were using some of their Medicaid dollars to subsidize dental care. So, yeah.
Okay, thank you for everyone who attended online and in person, and thank you, Steve and Maria Elena.